Hi, good morning.
Good morning, good morning.
Welcome to Coffee with Katzen. This is brought to you by Plastic Surgery 90210. That is a podcast page. Please go check it out on Spotify and Apple Music. What kind of coffee are you drinking today?
We have cappuccino again. How about you?
Oh, I have basically an Americano with oat milk.
Oat milk.
Yeah, love oat milk. All right, so we have lots of questions for you, but this week we did something kind of interesting. We did an eyebrow transplant.
Oh yeah. Really,
What the
really
heck
cool.
is that?
Eyebrow transplant, as the name implies, we transplant hairs to the eyebrows. So a lot of men and women lose eyebrows as they age. It can be genetic, it can be environmental, it can be due to some medical conditions. So this young female had thinning of the eyebrows, and she wanted them to be better. She was sick of using markers to fill them in. She was sick of using microblading and things like that. She wanted more a permanent solution. So she had a good crop of hair on the back of her head. So we harvested hair from the back of the head, harvested about 1,000 individual one-by-one hair grafts. We take out one hair at a time and then transplant them one hair at a time to each eyebrow, about 500 hairs to each eyebrow. So it should grow in nicely. In about 2 weeks, those hairs will fall out. They'll go through a phase called telogen. All the hairs fall out, and then they start to regrow back permanently.
And hair is a really good option to transplant because it's natural. It's your own hair.
Exactly. It's your own hair. You can't reject it because it's your own. Very rarely do you get infections the way we do it. And there's a high graft survival rate. Something like the way we do it, about 98 to 99% of the hairs will survive.
So basically what you see is almost what you're going to get.
You may lose one or two hairs here and there, but not too many.
Okay, well that's awesome. And is our patient happy so far?
Very happy. I saw her yesterday and she's very happy.
Maybe you could walk us through the process of what happens when you arrive to get a hair transplant, because sometimes people aren't always prepared for the fact that they do shave a section of your head.
Yeah.
Or the harvest area.
So the hair transplant, it's sort of a dual process. You need to give to get. Okay, so you need to give some hairs up to get your eyebrows. So on the back of the head, we shave an area. Depends on the patient, the size we shave, but that's the area where we harvest the hair from. We shave it down to maybe about 1 or 2 millimeters, and then we can see those hairs and individually pluck, if you will, those hairs from the back of the head. So it's, again, a two-step process. We get the hairs first from the back of the head, and then we transplant them. We flip you over, and then we transplant them to the front.
And it's important that we have to grab them from the scalp because you need the seed, right? The base.
Exactly. So when you look at hair, you see the external hair. Okay, it's the shaft of the hair, the keratin, if you will, the hair shaft falling out. And basically at the base, you've got the seed of the hair follicle, and that's what grows the hair. So you need to get the seed and the shaft of the hair. The shaft of the hair leads you down to the seed so you can pluck out the seed and the hair. So when we do a hair graft, a hair transplant, we are transplanting the shaft of the hair and the seed of the hair. So when we transplant it, we put the seed in, then after a couple of weeks, that shaft falls out, and then that seed continues to grow hair indefinitely.
It really reminds me of like gardening, like planting.
Yeah, exactly. But in this case, it's one hair at a time, one strand at a time, instead of like, and you're actually sort of like planting grass as opposed to like rice, where rice is more like clumps of roots. Seeds are one seed at a time.
True, Someone who are balding at the top were to do this section of their hair.
Yeah.
I have seen where they've harvested from this whole side area where there is hair.
Yeah, so we get hair where there is hair to transplant to hair where there's not hair. So we can't really get hair where there is no hair.
Right.
So we go for donor sites, and typically the donor sites will be at the back of the head and sort of as it goes over the ear. Usually those are pretty consistent areas, male and female, to harvest hair.
And it doesn't, and I think a common misconception is that the harvested hair will not grow back.
Oh no, it grows back. It grows back. And it is of a density that if you do miss a couple of hairs back there, the surrounding hair grows in that area. So it kind of covers up that area.
Okay, so hair transplant. That's a good option. You offer it.
Yeah.
And the techs that we use, so our hair technicians have been doing this for over 20 years. Yeah, they've been in practice for a very long time.
And they've done over 1 million hair grafts. So think about that. That's a lot of hair.
Yeah.
So yeah.
That's
so
a crazy
they're very experienced, and they sort of know the optimal techniques to graft hair. You know, what you want to do is you want to do one hair at a time. You don't want to do it robotically or it looks very patterned. You want to make it random. And then also when you lay the hair, you want to position it in the natural way the hair grows.
Okay, so let's move on from hair transplants, but if anyone has any questions, please let us know.
Yeah.
How did your experience at Duke University and the Medical College of Virginia shape your career in plastic surgery?
Oh, wow. So Duke University, pre-medical, do a lot of basic science courses, you know, chemistry, biology, physics, all that hardcore stuff. And that sort of prepares you for medical school. And then you go to medical school. Medical school, the way I went through 4 years, of course, the first year is all sort of natural, normal stuff. So you basically blow through, you know, anatomy, biology, physiology, biochemistry, all that in the first year. Second year is all the abnormal stuff. And then the third year is sort of all clinical. So you're hands-on with patients. So during your third year, you sort of develop usually an affinity to what you like to do and what you want to do with your career. So in my experience, Medical College of Virginia, I like the surgical fields, and that led me to a surgical path.
Okay, and did you have fun in school?
Fun in school? Fun in school? Not really. I mean, it's a lot of work. A lot of work. But sort of at the end, you're like, wow, yeah, it's worth it. But going through it, it's tough. I mean, medical school is not easy. Residency is not easy, and then especially surgical residency, I think, is probably the hardest residencies you can go through. And then plastic surgery is, when I went through it, it was definitely one of the longest residencies you can go through.
Would you say that medical school and residency was more difficult than private practice?
It's different. It's different. Residency, the hours when I went through were very, very tough, very, very long. But in private practice, the way I've structured it, it's equally long. So it's just different responsibilities. That's all.
And what do you prefer?
Oh, sometimes I prefer residency. Sometimes I prefer private practice. Just sort of depends on the day. Yeah.
It's a whole different type of responsibility.
Exactly. Exactly.
Yeah. You have so many patients under your care. How do you manage to see all of your patients?
Yeah, so we see them either in clinic or we see them virtually. I also have a wonderful physician assistant. Physician assistant basically is a junior doctor. And she is there all the time and can help insulate the load and also see patients either physically or virtually for me. So we have a great team in addition to that. I mean, it all goes up from the scheduling team. Anna, who fields the call, triages the call, makes sure it's can it wait till tomorrow or next week or whatever to schedule it, or does it have to go right to Dr. Katzen in the operating room? So she triages that. Then we have a secondary team, Jessica, who does the surgical scheduling, and then Brenda and Jane, who sort of manage the practice in terms of consulting with patients, giving them prices and sort of setting up the surgical date and things like that. And then a wonderful social media team.
Yay. And do you prefer virtual or in-person consultations?
Yeah, I prefer in-person. But look, this is 2023. You know, the technology is moving very, very quickly. So it's the convenience for the patient, too. So you have a patient internationally that has a problem, so they can consult with me, many virtual platforms, and get an accurate diagnosis and accurate treatment plan within minutes, as opposed to flying all the way here, spending a couple of nights in a hotel, renting a car, finding a parking space, coming up to the office, doing the consult, and then going back home.
Okay. Plastic surgery is a big deal. It's a big step. And if people are nervous about coming in for even a consultation or a virtual consult, what would you say to them?
It's just a consultation. It's not, we're doing surgery that day. There'll be no physical pain. There is a little bit of an emotional step to sort of get over that hurdle going, oh my gosh, I'm going to be naked maybe in front of a physician or somebody else examining me for a problem area. That can be a hurdle, but you've got to get over that hurdle to sort of get what you want in the end. So besides that, it's pretty harmless, pretty benign. We can even make it more less intimidating by you sending pictures ahead of time, so you don't even have to get naked in front of me on a screen. Of course, before we do any surgery, we're going to physically examine you in the office, make sure everything makes sense. But at least for the preliminary assessment of the problem and the problem areas, we can usually do that with pictures.
Right, and there are different reasons people come to you. You specialize in reconstruction after massive weight loss, and then also silicone injections removal. They're completely different.
Completely different problems. Silicone injections, very, very difficult problem to treat. It's an epidemic proportion, people all over the world have these problems, and the weight loss community, there can be, significant areas impacted. So just because of your weight loss doesn't mean, we're just doing the tummy. It can affect the thighs, as we did yesterday. It can affect the arms and the breast and the back and the face. So sometimes it's not just one surgery we're doing, but many, many body parts to get the body reconstructed.
And for silicone injections, it's like when they do come in for that consult, we know that they're taking the first step to improving themselves and to remove this product that's poisonous and toxic. Yeah,
so one of the big steps with silicone removal is getting rid of that sort of mentality that, it's going to go away, or it's fine, don't mess with it. If there's no problem, there's no problem. Well, I disagree with that. It's going to become a problem. It's going to migrate. It's going to cause you issues in the future. So get it fixed before it starts to spread. So getting over that step of, oh my gosh, I better get this treated sooner rather than later is a big step. But you've got to come to grips with that on a personal level.
Right. One thing that really excites me about all of your patients is that we know everyone walking in here wants to better themselves. Yeah, everyone has the same goal. You want to better them, they want to better themselves, and everyone is trying to be as healthy as they can be. So what do you think about that?
So, I think it's a very important thing. The goal should be for humans to better themselves and improve themselves in all fronts, emotion, physical, etc. And we're here a lot for the physical portion, but that also trickles into the emotional portion too.
And can you give me an example of how you were there for someone emotionally throughout their process?
Yeah, so we had an amazing patient about 15 years ago, and she had lost about almost 300 pounds. And we did her circumferential body lift. A couple of months later, we did her thighs. A couple of months later, we did her breasts. And all these were approved by insurance, and we did them in the hospital. And then on her last surgery, her arm surgery, the nurses called me from the hospital, something like 2 o'clock in the morning. Dr. Katzen, this patient's crying. I'm like, okay, is she in pain? She's not in pain. I'm like, well, what's she crying about? She doesn't know what to do. I'm like, what do you mean she doesn't? So they connect me with the patient. And I'm like, so what's going on? She was very, very emotional. She had that sort of hyper crying where you can't catch your breath kind of crying. Okay, and she basically said to me, she goes, "What do I do now? How do I behave as a skinny person?" I'm like, I don't know. I mean, that's something you grow into and you sort of become accustomed to. So I helped the patient through that, going, you just behave your normal self, but she couldn't wrap her head around now being much, much smaller and thinner on how to deal with her interaction with other people. So there are these things that come up with the weight loss and getting rid of the skin that you wouldn't even think of.
That's interesting. I mean, you do say that sometimes it takes people years to wrap their head around their new bodies.
Yeah. So we get a very, very common, patients will walk in front of a mirror and go, "Whoa, who is that?" and the brain won't catch up with the body. And we find sometimes it takes a good, sometimes year or more for the brain to say, oh, that's me. Oh, wow, I look much skinnier. Wow, I look great. And it takes a while because sometimes the brain is so used to over years and sometimes decades of looking in the mirror and seeing something and it gets accustomed to that. So when the brain sees something different, it doesn't know what to do.
And I think patients that experience this also have to realize that they brought themselves there. They lost so much of that weight, and you helped them finish it off, basically.
One of our mottos is complete the journey, which is sort of getting rid of that excess skin, getting rid of that excess fat to sort of almost cross that finish line after the weight loss. Because a lot of the times, unfortunately, after the weight loss, you're not done. You're left with a lot of sagging skin and skin that just doesn't recoil. No matter what you do, no matter what kind of diet or exercise you do, contrary to a lot of what physical therapists will tell you, oh, you just need more exercise, or contrary to the nutritionist, oh, you just need to lose more weight. Well, no, that skin's not going to bounce back. You may need some of these plastic surgery procedures.
Right. And plastic surgery, it's important to go to a plastic surgeon, a board-certified plastic surgeon.
I would think so.
Yeah.
You know, when I'm looking for a cardiologist, I look for somebody that specializes in the heart, like a cardiologist, not like a pediatrician or not like a GYN. So in my mind, if you're looking for a plastic surgeon, you should look for a board certified and a board certified person in plastic surgery. Makes sense to me.
Yeah. We do see a lot of revisions, unfortunately.
Yeah, a lot of revisions from people that pose as plastic surgeons, people like GYNs, people like dermatologists. Unfortunately, it's not illegal, but we get a lot of revisions, and the patients look, gone through a lot of misery and suffering, and they have deformities after just to save a couple of bucks, and that's not a great idea.
Right, and naturally after your first surgery, you will have scar tissue, and it doesn't make the revision any easier.
Yeah, for revisions, it actually makes it harder because the anatomy has been disrupted, and there's a lot of scar tissue in there.
Okay, great. Let's see. Can you explain why you became a professional in the 360 body lift?
Yeah, I love the body lift because it's one surgery that encompasses multiple body parts. It takes care of the tummy, the pubic region, the hips, and the backside in one surgery. So it's a very dramatic surgery, and in my opinion, huge results in one surgery. Sure, you could stage it. You could do the tummy tuck one day, a couple of months later do the hips, a couple of months later do the backside, and there's some surgeons in this building that do it that way. They'll do the tummy one day, and then 3 or 4 days later come back for the hips, 3 or 4 days later come back for the buttocks. To me, it doesn't make any sense at all. And even every day on the internet, I'll see some surgeons recommending to their patients, oh, no, it's very unsafe. We don't know the recovery position. You shouldn't do the tummy and the backside at the same time. I completely disagree. We've got hundreds and hundreds of body lift pictures and patients you can talk to. It's a very successful surgery. You can do it in one surgery. And I also love the dramatic results. In one surgery, boom, the body looks totally different.
And it's one OR and anesthesia date versus multiple.
Correct. So, if you do the tummy and the hips and the buttocks, that's 3 surgeries, 3 anesthetic risks, 3 risks of infection because you're recovering 3 times, 3 risks of blood clots and things like that. So the risks of multiple surgeries are there in comparison to one surgery.
Also a longer recovery time if you're
adding them up.
Yeah.
So if you do 3 surgeries, consider minimum 2 weeks recovery on each of those. 2 times 3 is 6. So that's minimum 6 weeks recovery, as opposed to a body lift, maybe 2 or 3 week recovery. So you can do the math.
So might as well go to someone who does it all the time and get it done at once.
I would, yeah.
Yeah. Let's see. How do you ensure that each patient is actively involved in the decision-making process for their personalized surgical treatment plan?
Yeah, great question. So I have a checklist of areas that bother the patient. So even before I see the patients will check off these areas. The tummy bothers me, the thighs bother me, the breast, the back, etc. They'll check all these areas off. I'll run through their medical history, make sure it's safe to do the surgery. And if it's safe to do surgery, then we'll analyze the body. Typically what we're doing is the tummy and thighs first, and then the upper body second. And then once we come up with a surgical plan, then I'll sort of backtrack and ask the patient, okay, that's my plan, but what bothers you the most first? So typically it's the tummy, and we do those, but sometimes you'll get the patient, oh, my arms bother me the most first. So we do that part first. I like to address the area that bothers the patient most first. That's usually how I try to structure things.
Okay, got it. And that's how you make sure they don't walk out of here with like a rhinoplasty when they're coming in for a body lift.
Yeah, I hate the plastic surgery practices where the patient walks in for one thing, and when they leave the office, they've signed up for something completely different. I don't think that's fair or right to do to a patient.
Yeah, you're not like a seller. You're just trying to help them with what bothers them.
I try to get the area treated that bothers the patient.
Okay, great. And let's take some audience questions for a bit.
Yeah.
We have a comment from a patient who had silicone injection removal from Dr. Katzen.
Okay.
She said that you gave her the tranquility that she needs when she was depressed days after her surgery.
Yay.
Aw, that's so nice.
Thanks for watching, and thanks for your kind words. I'm glad we could help you out, and I hope that silicone poison now is out of your system and you're doing much better. So thanks for the kind words.
And she's asking about BBL and buttock implants and if you offer any promotions. And she doesn't want to go to anyone else because she loves your results.
Oh, well, thank you very much. Yeah, so we do have promotions. They sort of come and go as the seasons come and go.
Yeah.
They're sort of not predictable, so just always just keep abreast of our office and the not sales, but the discounts and the promotions that we're having.
I would definitely say call our office and get in touch with Jessica or Jane, and they can always try to help you out with something.
Yeah. Yeah. So yeah, BBLs can be done after silicone removal. Buttock implants can be done after a silicone removal. Sculpture can be done after silicone injections. And they have a new technology now called M-Sculpt. You may want to look at it too. It stimulates the muscles and helps the muscles grow. And of course, number 5 is always exercise. Stairmaster, lifting, squats, etc. can help build the tissue in the buttocks.
But give us a call and we'll try to help you out as best as we can.
Yeah.
Yeah. I hear that a lot. Your like silicone injections patients, they say they will only go to you for reconstruction. Do you hear that too?
Yeah, that's very kind. It's very generous. So we do a lot of reconstruction of the buttock. I think it's very important. Not everyone needs it. But for those patients that do need it, we do have options.
Also, it's different than a normal BBL.
Oh, absolutely.
Yeah, let's
100%.
talk about that.
So yeah, with the BBL, BBL is usually a cosmetic procedure. We're taking fat from one area, typically the tummy and the love handles and sometimes the back, purifying the fat, getting the good fat, and then transplanting it to the buttock to get a bigger buttock. And basically, these are cosmetic procedures. They're not really reconstructive procedures. So for cosmetic, the difference between reconstructive and cosmetic is you imagine a normal patient in the middle. Okay? So you have a normal patient in the middle. A reconstructive procedure is to take a, quote, abnormal patient and do reconstructive surgery to make them look more normal. Okay, so that's reconstructive procedure. An aesthetic or cosmetic procedure is we take a normal patient and we make them, quote, super normal. So we take a normal patient and we make them super normal so they have a super big butt or a super whatever other body part. So that's a cosmetic procedure. So reconstructive takes abnormal, if you will, to normal, and then cosmetic goes from normal to sort of super normal.
Right. And what was the most challenging case you've worked on involving after weight loss surgery?
Yeah, we've had some very large paniculectomies. Those are, getting rid of the excess skin that sort of hangs. Many cases where the pannus, the excess skin and fat, sort of hangs below the knees.
Right.
Those can be very challenging cases for a variety of reasons, not just getting rid of the excess skin and fat, but also helping that patient to heal, because those are very difficult cases to make sure the patient heals just right without opening up the incision.
We have a video coming out on that soon.
Yes, that'll be good.
Yeah, that patient, I think he was over 700 pounds at his max.
Yeah, and I think we removed a little over 70 pounds just from his pannus, just his abdomen.
Right.
So not his hips, not his backside, not the 360, not the thighs, not the total weight removed, just his tummy, just his pannus, 72 pounds.
Just the part that hangs over the belt line.
Yep.
Yeah, not even a full tummy tuck.
Yep.
Yeah. So that's pretty insane, and his life is totally changed.
Oh, absolutely.
So much happier.
Yeah.
He even got a different car.
Yeah, exactly, because I think he described, because the pannus, his tummy was so big, he had to have the seats brought backwards.
And it would sit on the floor.
And his tummy would sit on the floor, and he was like this driving. After we took care of the tummy, I think he had to sell that car to get a new car,
right.
Which is a good thing.
Yeah, absolutely. Yeah. All right. Do we have any questions or comments right now?
Yes, we do. Viewer said she is curious because her friend had reconstruction surgery after silicone injection removal, and she got buttock implants and has to put injections on the side because the implants show on the exterior.
Yeah, so maybe the implants were too wide for her buttock. So when the implants are too wide, you can see the side of the implant on the hips. So you can camouflage or disguise that with fat grafting. So you typically get like a BBL, fat from the tummy and the hips, and then transplant it onto the hips to camouflage the implant. Another way you can do it is we have hip implants, which we've done on some patients too, where you put the implant on the hips to camouflage the buttock implants. That works well too.
Yeah, you have a patient with hip and buttock implants, and she has the perfect shape.
Yep.
Yeah.
Yep. After silicone removal.
After silicone removal, she actually does photo shoots now.
Yeah, cool.
Yeah, awesome. How has your experience in burn surgery, microsurgery, and craniofacial surgery fellowships influenced your approach to plastic surgery?
Well, all the burn surgery, microsurgery, hand surgery, craniofacial surgery, those are all components of plastic surgery. So it's not like they're individual. They all sort of go together under the umbrella of plastic surgery. So they each sort of go together. With burn surgery, we do a lot of skin grafts and flaps. So we do a lot of flaps in the silicone removal for the buttock. We're advancing large flaps. So each specialty has its own little component that adds to your training.
And we actually get a lot of questions on Real Self about people who have hernias and want to go for a tummy tuck.
Oh yeah. So those are, again, reconstructive things. Hernias are basically a hole in something that allows something else to go through it. So it's like a door. Okay, so something from one room can go into the other room. So typically it's in the abdominal wall, and it can be in the groin, it can be around the belly button, it can be around the incision, but usually a piece of fat or a piece of small bowel can go through that little hernia. And the potential problem is that thing that's going through the door gets stuck. And when it gets stuck, it runs out of oxygen and dies, and you can get very sick, and you can actually die of an incarcerated, like a stuck hernia. That's why we like to fix the hernias sooner rather than later. Typically with most hernias, you should get it fixed within about 6 months of diagnosis.
Okay, and a lot of people that are on Real Self are saying that, they want a tummy tuck, but do I have to get my hernia fixed first?
Yeah, so yes, you should, but since I have so much experience in general surgery and plastic surgery, usually your plastic surgeon should be able to fix your hernia at the same time as your tummy tuck. However, I do know some less experienced plastic surgeons who say, nope, go see your general surgeon. Your general surgeon will fix your hernia. Then 6 to 8 months later, come back for your tummy tuck or your body lift. Well, yeah, that's unfortunate for the patient. But when we do tummy tucks or body lifts, I usually fix the hernia at the same time by myself. Other plastic surgeons sometimes will coordinate with the general surgeon, where the plastic surgeon will open up the tummy, get to the hernia, general surgeon will come in, repair the hernia, then he or she will get out, and then the plastic surgeon will finish the tummy tuck. So that's another way to do it.
But another good example of how your training has come in to help you be able to do these things.
Yeah, so when we get in there, sometimes we'll find an accidental and incidental hernia. That means we're doing the tummy tuck and, there's a hernia. We had a patient maybe a couple of years ago where we found 6 hernias that she didn't even know about. Slowed down our surgery, but we fixed the hernias as opposed to doing the tummy tuck and then waking the patient up saying, sorry, you had 6 hernias, you're going to have to see a general surgeon. No, we fix them because of our training.
Okay, awesome.
Yeah.
And let's see, we're about to end this live, so let's actually ask you one personal question.
Oh, I don't like the personal questions.
If you could go back and relive one day in your life, what would that day be? Just one day.
Just one day. There's a good day. Great Barrier Reef in Australia. It's sort of the northeast coast. You go out in a boat. You go out for about, I think you motor out for about 3 days, and you're on the Great Barrier Reef, and then you just go scuba diving all day long. You get in about 6 dives a day. So you wake up, you go dive, you come up, you have breakfast, you look at all your pictures, then you go dive again, and then you do that, repeat the whole day.
Until
That's a good
nighttime.
day. That's a good day.
That's your perfect day?
Perfect day. And then you go diving at night too, which is a totally different thing. But yeah, that's the perfect day.
And for those of you that don't know, Dr. Katzen is very into scuba diving.
Yep.
Yeah.
My passion. So yeah. And underwater photography too. And underwater videography too. Yeah.
Wow.
So
will you ever show the audience some of your work?
Maybe. We'll try to dig it up. Yeah.
Are you gonna try to go scuba dive sometime this year?
We try to go every year. COVID's been difficult, but we'll try to go this year.
Okay, good.
Yeah.
All right, well,
Warm water though.
warm water. Oh, okay.
Yeah.
Only warm water.
Well, we did cold water, but it's so cold.
Miserable.
No, because you get to dive, but it's careful balance.
Ugh. Do you get used to the cold water, or?
You get numb. You start to shiver. And you shiver underwater, and your regulator, your thing that pumps oxygen off your tank, as you're shivering, it's like rattling in your mouth. So it can get a little cold. Yeah. And then if it gets too cold, your mask fogs up. That's what I'm at.
Oh my goodness. Yeah. Well, good thing you have a camera to see for you.
Yep.
All right. Well, thank you for joining us for another Coffee with Katzen, brought to you by Plastic Surgery 90210. Please tune in 2 weeks from now. We go live on the first Tuesday and the third Tuesday of every month. So we'll see you in 2 weeks.
Yay.
All right. Thank
Thanks.
you so much. Bye-bye.